Welcome back to the Oncology Journal Club podcast, your essential dose of the latest oncology research, expert analysis, and our trademark blend of healthy skepticism and bad jokes. Brought to you by the Oncology Network. I'm your producer, Rachel Bevan, and I'm once again joined by our Journal Club dream team, Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. This week's episode really does contain multitudes with an incredibly eclectic mix of papers. Craig looks at the effectiveness of cancer control measures and at optimizing drug dosages. Kate talks us through interactions between solid neoplasms and the microbiome and shares a curious paper on extra virgin olive oil. CJ tackles a sobering paper on substandard anticancer medications in sub-Saharan Africa, and also looks at what lessons can be learned from KEYNOTE-585 and Matterhorn in gastric cancer. We have a great selection of quick bites and a heartfelt discussion about taboo thoughts and the challenges carers of people with brain cancer face. We hope you enjoy listening to this thought-provoking episode. If you'd like more information about the Oncology Network and the Oncology Journal Club podcast, head over to oncologynetwork.com.au. And just a quick heads up, our 2025 Christmas special episode will be out soon, so you can expect more fun antics from the OJC team then. Thanks for tuning in. Let's get started.
G'day. Welcome to the Oncology Journal Club podcast. G'day, Dr. Clarke.
Hey, g'day, Craig. How's your man flu treating you?
Yeah, I'm over the man flu. Thank you. It is a thing. And Professor Jackson agrees with me. There's scientifically proven evidence.
I just don't think people, well, when I say people, I mean women, take man flu seriously, Craig. I mean, you and me understand the seriousness of this condition, but for other people to diminish its severity, they clearly just don't understand illness.
Yeah.
Don't you think that new drug, TTFuimab, has really changed man flu for life?
What was it?
TTFuimab.
It's TTFuimab, or what was it?
That's what I thought you were saying too, Craig.
TTFuimab. Yeah.
TTFuimab, is that the one that you serve with a cup of concrete, Kate?
Yes, very much.
Well, it's good to know our co-host is so empathic to our I've got to say the bug that I had was really serious. I mean, I was almost in ICU with it, for 48 hours. And the fact that I recovered so quickly is just a testament to my wonderful constitution and the strength of my character. I'm sure it was the same for you, Craig.
Yeah, absolutely. So we've been very heartened recently by the number of people downloading the episodes and for the nice feedback we're getting. So please keep it up. Let us know if you have suggestions for papers to cover or topics. We're trying to reach a fairly general audience, and today's episode I think is a good example of a fairly eclectic mixture of topics. So let's get straight into it. I'm going to go first today. So I have a paper from the Australian New Zealand Journal of Public Health from June from Lynch et al. With cancer control measures have prevented 230,000 deaths in Australia since the mid-1980s. So I'm sorry for the 10 listeners in New Zealand that this is focused on Australian cancer control, but I'm sure you could extrapolate similar results in New Zealand population as well. So this is from a team led by the Cancer Council in Victoria. They wanted to estimate the lives saved because of cancer control measures implemented in Australia since age standardized mortality rates have been available, which is in the 80s. And so they looked at estimated the expected number of cancer deaths, the number of avoided cancer deaths and standardized mortality rates over time. So the overall age standardized mortality rate peaked for females in 1985 and then declined. For males, it peaked also in the mid-80s and has then declined. So overall, they estimated that there's been 66,000 female lives saved, 164,000 male lives saved, and that might reflect the earlier drop-off in smoking rates in males. So overall, that's an 11% reduction in overall cancer mortality in that time. So this is going out to 2018. And of course, since then, we've seen lots of new treatments coming into play, immunotherapy and targeted therapies in various cancers. We've also seen National Bowel Cancer Screening Program in Australia, which is thought to have led to further reductions in mortality. So the overall take-home message from this paper was that all of the cancer control measures put together in that time has led to a significant reduction in deaths. Just of note is that we've seen improvements really right across all cancers, apart from one, and that's liver cancer. And so we haven't seen reductions in the age standardized mortality rates in liver cancer. So that the suggestion from the authors would be that this could be a focus for targeted research going forward to really try and bring into play reductions in liver cancer, which is becoming more prevalent, not through both viral mediated, but also through metabolic liver disease and other risk factors such as alcohol intake. So anyway, I find it's always interesting to sort of take a bit of a step back and look at progress made and where we're going. We tend to present a lot of papers about new treatments in individual cancers, but this was a nice kind of snapshot about where certainly we are in Australia. It refers to some data also in Canada, which is similar. And as I said, I think it probably makes some similar assumptions in New Zealand as well.
Behind all that data, there's some real complexity, Craig? Like, so endometrial cancer, for example, is certainly going up. And then you've got the premenopausal versus postmenopausal breast cancer discrepancy as well. And then whilst you've got the age-specific reductions in colon cancer, which are going down for older people, the curve in the younger people's ticking up slightly as well. So while the individual risk of cancer is lower than it ever has been, primarily due to cessation of smoking, for example, and known risk factors, there are clearly others where modifiable risk factors, particularly obesity, remain a really important feature, and our efforts in cancer control still far from done. What is it? 30% of all cancers are related to what they call preventable risk factors, which are amenable to social policy intervention, and particularly things like air quality and the like are going to be big features in EGFR mutant lung cancer in years to come.
Yep. So when you say an uptick, Chris, you're talking about the incidence now. So what this focused on was the age standardized mortality rates, which you mentioned uterine cancer, for example, that hasn't really been, there's an uptick in incidence because of the aging population, but not an uptick in the mortality rate. So as our treatments are better.
Yeah, well, there's obviously incidence, there is survival, and there is mortality. And where you have your incidence going up and your survival rate's the same, then your mortality will go up because you've got more cases, right? But if your incidence goes up and your survival goes up, then your mortality can go down. But those ones where you've got a higher incidence, such as endometrial, for example, I mean, that's a genuine increase, definitely in Māori New Zealanders in the Pacifica, for example, in our population, and that's going to lead to a genuine increase in death rates, so mortality will go up from there.
Yep.
Yes. So that's what I was going to say, is that this is all very well looking at all, however many Australians there are, but I suspect if you broke this up by ethnicity, a decile of wealth, that there will be communities that are not benefiting as well from many of the interventions that are helping those that are well served in the health system.
That is a really fascinating that you said that, because when the authors posted this on LinkedIn, that was my question to them. Could they do the same work, but actually to look at some of those priority populations? So let's look at whether we've seen the same fall in regional populations and then extrapolate out, well, how many lives haven't been saved in those populations because we haven't been able to bridge the differences in outcomes between, the privileged populations and some of the priority populations. So that would be a really fascinating piece of work. Hopefully the authors may take that on board and look at some of that. So this is overall Australian population. They haven't teased out those very issues that you've raised.
Yeah, and fascinating data on skin cancer as well. So in populations around waterways, the incidence is going up, so people are detecting it more often, but the cure rates have remained identical. Similarly, for prostate cancer, the incidence is going up, but actually that's to do with PSA testing, And then the mortality itself has remained broadly similar, so there is a disconnect there. And the points that you've raised, Craig, around identifying priority populations, we're really blessed in New Zealand to have some very gifted epidemiologists who that's a very core part of their work. And our good friend and colleague, Professor Jason Gurney, does exactly that with priority populations. And I've added my name to a couple of his papers by post-it note on occasion. So it'd be great to have Jace on the show at some stage to talk about how that works in at-risk populations. We should do that, at some point soon.
Sounds good. So this was dated to 2018, Chris, so we haven't really seen the impact of the new melanoma treatments in this data. You'd expect there would have been quite a substantial move.
And the lockdown phenomenon too, right, where your diagnostic work went down to see what happened with mortality rates.
Yep. All right. So let's move on. Kate, what have you got for us to talk about today?
So I want to talk about I think it's called a review article, but it's probably not really one, in JCO, and it reminds me of Walt Whitman. I am large, I contain multitudes, because it's about the interaction between solid neoplasms and our microbiome. Just to run through this quickly, because I was told I was not allowed to wax on lyrical for too long. 3 current approaches to influencing one's microbiome and its interaction with your cancer. Prebiotics, which is probably where the money is, so high fiber diet. The best outcomes in patients on immune checkpoint blockade is in those people who have a dietary fiber intake of greater than 20 grams a day and no probiotics. And it is a dose response curve, so improved outcome at every 5 grams per day of fiber. And in case you're wondering, a breakfast of oats and berries has 10 grams of fiber, so you've got half of your fiber in a day. 1 cup of baked beans, 14 grams. So that's pretty awesome. The probiotics have been looked at mostly to try and counteract the fear we all have of antibiotics pre-immunotherapy disrupting the gut microbiome and lowering over response rates. We've all seen that. But you don't want to not treat people's infections, so it gets very complicated. Or fecal microbiota transplantation. So the sharing of fecal slurry. So there are 2 phase 2s in patients with immunotherapy-resistant melanoma who were treated with fecal transplant from someone with a deep response to immunotherapy, and those people that had been resistant then went on to have a 30% response rate at re-challenge. So absolutely fascinating.
Fascinating, but gross.
Yeah. I don't know about your MDM, but our gastroenterologists sometimes come with a brown paper bag, which they give between them. We all know what's in that now. Brown paper bag is a fecal transplant. We're really only using it in our centre at the moment for patients with intractable Clostridium or some inflammatory diseases. We haven't been tempted to use it in immunotherapy-resistant melanoma. But, if we're not going to get ipilimumab funded, it might be what we have to go for.
Don't you see the market here, though? People ending up selling their poo, the super responders, and then ending up with a poo bank that people can, there must be something in there. Or maybe people are just going to be looking for the bacterial products, which are going to be the ones which are associated with that of the microbiological signature, which you can then actually engraft. So it is fascinating, eh?
Yeah, it is. I think this is TMIMAB, and we should move on. But I think we could do a whole... Yeah, we could do, that's great. We could do a whole episode on the microbiome. I think it's a really fascinating area.
How many grams of fibre are there in bagels, Kate? Because I'm quite keen to know that.
Oh, sweetie, you'll need an everything bagel, I think, rather than your bland white nan bagel.
Oh, DJ, what do you bring to the table today? Hopefully not in a brown paper bag.
I don't have a white paper bag, but I've got some papers to rustle. I've had some feedback from a lot of callers that they really like to hear all my papers rustling in the background, so they've asked me to do more of it. So I promise today, Craig, I'll rustle my papers regularly. Oh, it's great. I don't really out-rustle by you, though. So the long paper I wanted to talk about today was Substandard Anticancer Medications in Sub-Saharan Africa, a systematic pharmaceutical investigation, which was published recently in Lancet Global Health. Now, why this matters? Well, cancer treatment demand in low and middle-income countries is exploding, but actually there's surprisingly little surveillance of drug quality. Now, that's something that we take for granted in high-income countries, that what you get in a vial is what it says on the box. But apparently that is not true worldwide.
Wow.
And there are people in pharmacies abroad that will vial split and mix it up with water in order to charge patients full price in order to make profit, or people who are unscrupulous and will just sell water. And there was a bevacizumab scandal whereby all people were getting instead of bevacizumab was water. You can argue over whether that was of detriment to them or not, but certainly when people are paying for stuff, they should be getting it. So what this group did was they took 251 samples of 7 key drugs from low and middle income countries. So these drugs were cisplatin, oxaliplatin, methotrexate, doxorubicin, cyclophosphamide, ifosfamide, and leucovorin. So pretty core oncology drugs, right, that they're testing for whether or not what they say on the box is what you get in the vial. They sourced these samples from 12 hospitals plus 25 what they call private or grey market pharmacies across Ethiopia, Kenya, Malawi, and Cameroon. And they assayed using a liquid chromatography using US pharmacopoeia standards, which I didn't even know what that was, but apparently there are standards for measuring quality of cancer medicines. They also did a visual inspection of packaging. And what I learned from this article was that what does that mean? Well, when you look at a vial, is it the right colour? Has it got crystals or precipitants in it? And sometimes the boxes are just photocopies or downloads from the internet of a random vial. And some of the medicines or TKIs were just paracetamol, which is outrageous that people were getting paracetamol instead of their targeted therapy. Anyway, a full 19% of all products failed the chemical assay test. And the active pharmaceutical ingredient ranged from 28 to 120% of the label claim. So the quality of what people were getting was massively variable. Expired stock was 24% of all samples. So of all of the samples they got from pharmacies, a quarter was expired. Interestingly, expiry status didn't actually make it more or less likely to fail. And there was no difference found in hospitals versus the private sector. Unfortunately, the visual inspection was quite useless. So just looking at the quality of the box didn't actually help you, or looking at the quality of the medicine or saying, that doxorubicin's not the right colour. That didn't actually help particularly. So there was no correlation between visual inspection and medicine quality. And some manufacturers had failure rates of more than 70%. So 70% of cancer medicines from some manufacturers failed the basic assessment of what they said they did in the box. There are substandard or falsified anticancer drugs, and these are present in major hospitals and private pharmacies alike. And given that we've got globalised supply chains, this is likely an issue across other low and middle income countries globally. And this compromises treatment outcomes, research interpretation, and survival data. So whilst we have medicine regulation in terms of at the time of manufacture, we do not have robust post-market surveillance and regulatory tools in most countries. So once a drug is approved, that's generally it for surveillance. And that probably needs to change. We need to have low-cost screening tools. We have to improve supply chain management and supplier vetting. And we have to record lot numbers and brands in clinical practice and link these to outcomes and do some post-market surveillance. And this is a very important issue for low and middle income countries in terms of cancer medicines quality, given that this is where the burden of cancer is going to hit over the course of the next 20 years. And it's incumbent upon us to ensure that this is true. I was a little worried initially that this was going to be a scaremongering paper that was one of those ones that was used by Big Pharma to say, no, don't get your TKIs from generic pharmacies in India, etc., because it's just bad drug. You need to buy the full price medicine from us and pay $10,000 a month as opposed to the cheaper $600 a month you get from other countries. But this seems to be much more serious than that, and it's including these core drugs like cisplatin, doxorubicin, etc. So this paper really shook me up in terms of what I thought the quality was of people getting medicines around the world.
It's heartbreaking because not only was there a lot of underdosing, but that overdosing, depending on what the drug was, could have been significantly toxic. And was there any mention in the article about whether oncologists had a feel for which drugs were a problem?
Not that I read, but, I think one of the problems with clinical practice is, you sometimes see clusters of patients with side effects, right? And you start to think, oh, well, was that a dodgy batch? And you sort of chuckle to yourself about it. But actually, generic substitutions often only have to be within a band of, 15% variability anyway. So you can actually have quite marked variations in generic switching. So I think it is a thing that we have to watch out for. And I really like the recommendation around the post-registration surveillance stuff that we should really be looking at as a new regulatory measure. So I was pleased to see that the UICC made some very strong statements around this and have partnered with some pharmacy organisations also to make some recommendations. Whether they'll get picked up or not remains to be seen.
Thanks, Chris. Has a similar study been done in higher income countries such as Australia? Or have we had the same kind of audit process to see what the rates are?
Not that I'm aware of, Craig, and I actually couldn't, I'm certainly no expert in what the post-marketing regulation is in New Zealand, but I'm actually not aware of any post-marketing or random auditing that you get. When I worked as medical director of the cancer side of New Zealand, we would get stung every couple of years by a consumer who would check out our sunscreen and work out whether or not it met its SPF labelling. But, SPF 15 versus SPF 30 is like 99.8 versus 99.9% good. So that was always a bit subjective, and the methods for testing sunscreen are dodgy anyway. But I'm not sure we actually have those same standards for medical products. We just rely on the integrity of the supply chain of the manufacturer.
Yeah, and look, even I'm just Googling very quickly, and it would be really interesting if there's an expert listening, because the FDA have a very similar process to us, which is that CARMS, that doctors put in, oh, my patient had a bad outcome. But are they actually taking 100 milligrams of cisplatin and checking it's 100 milligrams of cisplatin? That's what I'd like to know.
Yeah, I don't think they are, but it'd be great. So if you're an expert out there listening to our podcast, let us know, because otherwise it's just us randos ranting on about things that we don't know too much about.
Okay, thank you. So my first quick bite is, I guess, segues from that a little bit. It's called The Totality of the Evidence Optimizing Dosage Selection Strategies Oncology, published in JCO in July. It's basically a discussion paper discussing the issue about drug development and how with the newer targeted therapies, it may be now we need a new paradigm. Instead of using conventional maximum tolerated dose to develop the dose, we should actually have a more sophisticated way of looking at appropriate dosing of these drugs, because there's been recent examples in some of the conjugated antibodies where post-marketing there had to be recommendations to drop the dosing down due to toxicity. So just something to note for people who are involved in clinical trials and drug development. Interesting paper published in the JCO. Kate, I came across one, and you do more breast cancer than us. Aprepitant use during chemotherapy and association with survival in women with early breast cancer in the Journal of the National Cancer Institute in July. So showing that this is a retrospective analysis, but suggesting that women who had received, this is done in Norway using some linked nationwide registry data, 13,811 women diagnosed with early breast cancer between 2008 and 2020 who had had chemotherapy and antiemetics, and showing that those who received aprepitant had a superior survival with about a 30% reduction in the risk of death. And this was strongest in women with triple negative breast cancer. So I don't know if you've read this paper, Kate, but I guess this is the assumed hypothesis would be that by using these effective antiemetics, women have been able to stay on the optimal dose of the chemotherapy regime, not had to have a dose reduction of their chemo.
Yeah, I think in the absence of interventional data, I think you have to say it's the anthracycline and the platinum dose intensity is possible with aprepitant, but a 0.7 hazard ratio, you think that's huge. And triple negative breast cancer is a really evil beast. So I suspect someone will. The tricky part is you couldn't randomize now women to not having the aprepitant in an anthracycline and a platinum. So we may never understand this. But if there's a clever scientist who can think of a kind way of figuring that out, I'd love to know. But I'm not giving my women with anthracyclines and platinums without, particularly young women cannot get through it without aprepitant. Craig, Chris and I are all old enough to remember when all we had was steroids and metoclopramide, and oncology was not a fun place to be sometimes.
Well, I remember my first job as a second-year resident was working at St Vincent's Hospital in Melbourne, and I was clerking in patients, and a huge proportion of people receiving chemotherapy on that day stayed overnight and were getting effectively sedated overnight to get through. So, and then I remember when I first came to Albury, I was allowed to give ondansetron to 3 patients. I had to pick which 3 to give these, like a supply program, and I could have 3 people to choose. So really, things have really changed. But I would have thought aprivatin's now built in, or other drugs in the same class are now standard of care, according to ASCO and MASC guidelines for these chemotherapy regimens anyway. Is that correct?
Yes, very much so, yeah.
So, yes, we'll never get a trial, but it would seem reassuring that, we do have to ensure that adequate antiemetics are incorporated into the chemotherapy regimes.
Yeah, I mean, these days with aprivatins, with olanzapine, metoclopramide, and ondansetron or an Aussie, obviously olanzapine, we don't have admissions for nausea and vomiting with chemotherapy now. It just doesn't happen.
Yeah, that's correct. Yeah, that's right. I mean, occasionally had a patient who, despite everything, was needed to come in overnight, but it's now very rare.
Just as an aside, there was an article published in today's New England Journal of Medicine, I think, where a neuronkinin inhibitor was used for hot flushes with women, and apparently works, but they were taking a daily neuronkinin inhibitor. So I've watched this space. I will look that article up properly.
Yeah, okay, maybe we can bring to that next time, Kate. And then my last one was a paper I found really quite confronting, I guess, triggering, unveiling the unspoken, exploring taboo thoughts and difficult experiences among carers of people with brain cancer, published in Psycho-Oncology in July. I found this quite triggering. Unfortunately, my father passed away of metastatic bowel cancer at the age of 67 with brain metastases, and actually died in status epilepticus. So it brought back quite a lot of memories of that terrible time for our family. But this is an interesting paper. It was a qualitative interview study in people with primary brain tumours, but I think same principles in people with brain metastases as well, and spoke about 4 themes identified in these interviews with carers about staying safe. So aggression and violence is an issue sometimes in these patients. Conflicting and complex emotions. I love him for who he was. There's a quote, wishing for the end with grief and relief. So this sort of guilt experience. And then the bad experiences of patient death and end-of-life treatment decisions. And carers talking about 5 coping strategies, being committed to care, life alongside the carer role, acceptance of circumstances, self-silencing, and information seek and safety planning. But the paper gives some guidance for clinicians and how to manage this issue. And firstly, it's about asking about how carers are coping and whether there is issues of, for example, of domestic violence, and then putting this suggested coping strategies that are talked about in the paper. So fairly niche paper, but I think with some learnings for everybody looking after people with cancer in most tumours where there can be brain metastases.
Thanks for sharing, Craig. My heart goes out to you and your family. Even though it's years ago, it doesn't go away, does it?
I don't know.
I also I think caring for carers, cancer isn't something that happens to one person. It happens to a whole community of people attached to that person. And the more that we as oncologists understand that and do our very best to hear the lived experience of patients and their carers, the better oncologists we can be. So I applaud you for bringing that to our attention. Thank you.
Yeah, I don't know how I came across it, but it just really resonated with me. And I think, as I said, it's quite a practical paper with some great suggestions about how people need to be aware of these issues and actually ask about them, and then some coping strategies.
I think that's what's really nice about that, Craig, too, isn't it? Is the practical suggestions for how to make a difference there, those coping strategies, And also the power of acknowledgement of people in those circumstances, even just to have your suffering seen, can be very relieving. We don't like to talk about the fact that actually, unfortunately, people with brain secondaries or primary brain cancer, it fundamentally robs people of their personality sometimes, and it does so that the individual dies before they're dead, before they go. Their personality goes, and it's cruel in the way in which it can take people's personalities.
Yeah, and then there's a whole, you're wishing them to be dead, and there's a lot of guilt about that. My dad's case, we used to say, Jim checked out a long time ago because he just wasn't the same person. But all right, let's talk about something a bit happier.
A bit more cheerful.
Yeah.
Kate, I think you wanted to tell us about some new treatments.
Yeah, so I'm going to start with a hematology one, and embarrassingly, I'm not even sure I can say this. So this is a long-term outcome from CARTITUDE-1, cute, siltacaptogene autoleucel, which is a B-cell maturation antigen-directed, genetically modified autologous chimeric antigen receptor T-cell therapy. Edith is going to love me saying that. Yep.
Congratulations on the pronunciation of all these big words.
So this was being given, it's this trial, patients were infused in 2018 and 2019, and so published only recently. 32 of those patients, 32 of 97 patients are still alive and progression-free, significantly more than 5 years after their infusions, potentially curative. Seems to be that the more well you are when you start, the better you get on. Curiously, the minimum residual disease negativity, so this is where you can't find anything on blood tests to demonstrate that the patient still has multiple myeloma. In this trial, CARTITUDE-1, was only 59%, whereas it's 73% in later trials. So the hope is actually data's just going to keep getting better. And in terms of the long-term toxicity, the extra toxicity, quote unquote, it's 2% solid malignancy and 4 serious infections. So feels like something that will be brought earlier and earlier, remembering that this population routinely have a life expectancy of less than 12 months. So it's miraculous. We as solid, all of us GI oncologists, are heartbroken about early onset colorectal cancer. Early onset multiple myeloma is also a real thing. So these are not all frail elderly people getting it. So that's pretty exciting.
This whole field's another exciting kind of, we talk about chemo, radiotherapy, hormone therapy, targeted therapy, immunotherapy, all these cellular therapies. I think is a whole new wave that we're all going to have to be informed about and refer patients for trials.
Very cool. Then another short bite that a patient drew my attention to, so thank you very much to that patient. An Indonesian group looked at using olive oil, drinking it, to prevent PPE, palmoplantar erythema, common side effect of capecitabine. And so what they did was everybody had to drink 30 mils of extra virgin olive oil per day. They compared that with a group that they called placebo, which was extra light olive oil. So I thought that was very interesting. So apparently extra light olive oil does not have any of the good stuff in it. In the instance of grade 2 or greater PPE in those patients that took the real extra virgin olive oil every day, 30 mils, 6 tablespoons, was 13% versus 67% of those on the placebo, which is the extra light olive oil. And so the theory is that extra virgin olive oil contains something called oleocanthal, which is very similar to a non-steroidal and inhibits COX-1 and COX-2. So there you go.
Amazing. I don't think we've ever had a paper from Indonesia. So this was from ActaMed Indonesia. Terima kasih to the authors from Indonesia. That's about the only word of Bahasa I can speak. That was thank you. So the old extra virgin olive oil, it's not just good for your salad.
Taking orally rather than topically, Kate.
Yeah, they were drinking 30 mils of it. Yep. I did actually, I had planned to try and drink 30 mils as a shot and see if I could do it, but I'm sorry, I just didn't go around to it.
You should see the way I cook. I mean, I probably use about 30 mils a day of olive oil.
I worked with a man at UCLH in London who was from Trinidad and Tobago, beautiful clinical oncologist, who used to, his secret recipe for his jambalaya was about half a bottle of olive oil. So I think for some communities it wouldn't be a problem.
I think it'll be hard to get past pharmac as well, given the price of olive oil these days.
Very true.
With that. And I'm presuming these people weren't having Voltaren hand gel at the same time, because the diclofenac hand gel from the trial in India has been something that we've adopted wholesale as well in our practice from some of the pharmacies. The generic is quite cheap or cheap enough. So we've been using that as a primary prevention now. Kate, have you guys adopted that up your way?
Yes and no. So yes, and politely, this is a yes when I remember. So this is one of those things where I think it would be very useful to have it on patient information so the patient reminds me. But yes, we do. And you're right, you do have to shop around, not mentioning the brands of the pharmacies, but there are some pharmacies significantly cheaper than others.
Yeah, and it's one of those ones that because it's not on prescription, you can't quite build it into your automatic prescription protocols. So it's a little bit harder. And yeah, you're right, you have to remember it.
Yeah.
So olive oil and Voltaren hand gel, it's a great combination there.
Yeah. We talked about the Voltaren hand gel on the podcast before. I think we have, Chris, but we might just also reference that paper in our notes for today. And Kate, do you have one more?
Yeah, just very quickly. So ESOPEC, which we've spoken about before, so flop versus cross, still lots of arguing in MDTs all over the country, I'm sure. Compliance has been discussed heaps, cross components saying that it wasn't fair, that the patients on cross didn't get enough. So Florian Laudix has published 95% of FLOT patients got all 4 pre-op doses, meaning that 5% didn't. I love German clarity about things. Cross, only 4% had less than 4 pre-op chemo doses. 99.4% received at least 41.4 grays. So what he's trying to say is actually compliance to both regimens was very high. Node resection was similar. Nodal clearance was very similar. A PCR rate was significantly higher in the FLOT than cross, so 17%, which is quite high, versus 10%. But the outcome is still clear that FLOT is better than cross, and we can't say it's because patients didn't get enough therapy.
Mm. Is there still debates about it? I thought pretty much.
Yeah, I thought it'd been settled.
Look, I think there's still some radiation oncologists who've got that. If you've read the original cross trial, did look like it had knocked things out of the park, but that's the naughtiness of that cross-trial comparison. So you have to do the proper randomization.
Just stop inviting them to MDT. That's what Neil Tabbert Justin would say.
Or the upper GI MDM, the role for the radiation oncologist is ever shrinking, isn't it?
Big shout out to any of our radiation oncologists listening. But yeah,
so some of my best friends are radiation oncologists.
Well, let's call it out. Radiation oncology and upper GI have got a series of points of denial. We use newer techniques now. Those old techniques in that trial don't apply to my patients. It was all about dose intensity. In my hands, they would always get that. And we're now using better imaging techniques to ensure that the fields are tighter so they get less toxicity. And that's always the full range of excuses. But I really do like the ESOPEC study because it did sort of settle it a wee bit. I also don't think there's any doubt that FLOT is a harder to tolerate regime than cross. cross is a doddle in terms of getting people through the 5 weeks of preoperative therapy. And if you've got a patient who's T3N0 or T2/T3N0, there's probably not that much advantage for a more intensive regime. And when people crash on FLOT, they crash really badly as well. So if you've got someone who's got frailty or comorbidity, it is still a debate. Also, when I talk to my colleagues who are in low and middle income countries about FLOT versus cross, actually they love the chemotherapy because you can deliver that regionally much more easily than radiation where you have to go to a centre, and so it's more deliverable in terms of their communities. So we have to be careful about recommending treatments that do dislocate people from the community.
Absolutely. So Chris, have you got some quick bites?
Are you asking Chris for quick bites or Russell?
Right, Chris, please.
All right. This week in my clinic, I've had a patient who has got a metastatic paraganglioma. Now, I've had a couple of these patients, and in our part of the world, we have a couple of patients who've got an SDH mutation, usually the SDHB mutation in our region. And the question was, how do we manage this metastatic disease that had become unresectable? And there was a bit of chat about peptide receptor radionuclide therapy. Now, PRRT, of course, Australia was a country who really did adopt PRRT early on and often led the world in terms of the implementation of that, with a large number of PRRT centres per head of population. And so certainly when I was learning the craft of neuroendocrine treatment, we learned a lot from our Australian counterparts who had a lot of expertise in that. And the New Zealand neuroendocrine centre has only been open for a couple of years now, but we've only got the one compared to Australia, for example. This was a study of 177 lutetium dotatate in patients with metastatic paraganglioma or pheochromocytoma, half of whom had SDH mutations, the other half who were sporadic. And what the study did was it looked at the response of people who had lutate therapy. And what it found was 6-month PFS in all comers was 86%, but lower in the SDH mutations at 72% versus sporadic, which were 100%. Median overall survival was 51.7 months in total, 31.2 months in SDH versus not reaching the sporadics. The SDH mutations were doing much, much worse than the sporadic and paragangliomas. The toxicity was mostly hematologic in terms of lymphopenia and anemia, and is usually not all that significant in terms of managing it patient-wise. And interestingly, with the pheochromocytomas being often adrenaline or adrenaline-secreting tumours, 17%, so 1 in 6, are getting grade 3 or more catecholamine release syndrome, requiring ICU-level care. The interpretation of the study was that lutate was active and generally tolerable in metastatic paraganglioma with durable disease control, but SDH tumours fare worse, likely due to aggressive pseudo-hypoxic biology and radioresistance. Why is that? Well, these cancers often display a pseudo-hypoxic phenotype with elevated HIF2 alpha and a hypoxic tumour microenvironment which drives radioresistance and faster progression. So the patients with the SDH mutation do worse on lutate, even though they still do benefit, and it's important to be aware of that. Just briefly, also just looked up also other available treatments of metastatic paraganglioma as well as lutate. There is evidence for sunitinib, PFS of 9 months, cabozantinib, PFS 16 months, and belzutifan, which is a HIF2 alpha inhibitor, which is FDA approved in 2025 with a 25% response rate. So there are some treatments available for this patient group, and important to bear in mind that mutation predicts a worse outcome for patients.
Amazing.
Another quickie here, Craig, which is the key results from the KEYNOTE-585 study. This was a randomized phase 3 study of patients with resectable gastric and GEJ adenocarcinomas. This is the same population as the Matterhorn study, which was DFLOT, so FLOT versus development FLOT in the gastric and GEJ patients. This was the KEYNOTE study, the pharma-sponsored study, looking at cisplatin fluoropyrimidine plus minus pembro. Towards the end, they did change that to allow FLOT plus minus pembro, but largely it was a cisplatin fluorouracil backbone involving a lot of Asian countries. The key findings were that PASCR was markedly improved with the addition of the immune checkpoint inhibitor of 13 to 40% versus placebo of 2 to 3%. And median event-free survival was 44 months versus 25.7 months with chemotherapy alone. A subgroup trends towards greater benefit in MSI high and PD-L1 CPS greater than 10. The MSI high patients do worse with chemotherapy generally, and the addition of a checkpoint inhibitor is probably no surprise that they do well. But why was this interesting? Well, this is a negative study, whereas Matterhorn was a positive study. So why was this study of cisplatin fluorouracil with pembro negative, whereas Matterhorn was positive? And does that tell you that Matterhorn was an outlier, so we should ignore it? Or is this a bad study, and therefore we should ignore it and accept Matterhorn in terms of adding in immune checkpoint inhibitors to your chemotherapy? Well, one of the interesting things about this was the backbone, of course. So just cisplatin 5-FU is not a standard in the West. The triplet chemo FLOT is certainly the standard, and that does worse. But also the way they did the study was they tested the primary endpoint of event-free survival at multiple times. And when you test the primary outcome at multiple times, you have to increase the alpha in terms of making the assumptions to reach statistical significance. But because they were so conservative and tested it so often, they ended up having a negative study. And perhaps if they'd only done it once, they would have had a positive study because the alpha would have been more reliable at that point. You would have had 2 confirmatory studies. So the take-homes were that pembro improved PASCR and trended towards better survival, but the trial was overall negative. Matterhorn, meanwhile, sets a new global standard of FLOT with durvalumab. And it shows the backbone matter, the statistics matter, and the biology shows that actually adding an immunotherapy probably does work.
So approved for use in your country?
Absolutely not, nor should it be. But I think it's a good lesson in trial design and how multiple testing of your primary endpoint does matter, and that if you get negative for EFS because you test at multiple time points, then that can affect your later interpretation if you spread your alpha over EFS and OS, and it stops your testing for that. and it shows the chemotherapy backbone does matter as well. So I found that an informative study for trial design, and I also found ultimately when I looked at the details and showed that the EFS was actually better, PCR was better, but we are getting a signal from another study that adding immune therapy to your backbone does actually make a difference, and it reinforces the rationale for development with FLOT, which is what the Matterhorn study tested.
I'm a simpler human, and one of the things that when you texted us very late this afternoon that you were going to have a look at that trial was I went back and had a look at FLOT AO4 and at Matterhorn, and the PCR rates are all very different, right? And I think this feels a little bit like the early cetuximab trials in that some of them were positive, some of them were negative, and you can argue your very cleverness. But I wonder whether actually there's something we're missing. There's a biomarker that we are missing, and we will look back at this and go, oh, why didn't we enrich that population for those people? Or why didn't we, and so I feel like we're on the verge of understanding something, but we can't see it yet through the wood, because the alpha in the Matterhorn's only 10%, which means and that's only EFS. We don't have OS yet. And the same is true in breast cancer. The EFS is about 10%, the OS is only 5%. So we're picking out a small subset of people and exposing all of them to a crap blood drug. So I feel like we're on the verge of something, but we're not there yet.
Yeah, I think that's a lot of fair points there, not least of which the fact that I sent you through the paper later, that's a particularly fair point. But also, when you look at the history of gastric cancer, 3 to 5 year survival with surgery alone, 23%. Add ECF adds 13%, gets you up to 36%. Then you do FLOT, it adds up another 10%, so you're up to 46 to 49%. And FLOT performs pretty reliably through the study as well. I mean, that's what's good. So the landmark analyses for FLOT are reliable. The landmark analyses for Cisplat-5FU are reliable. And you're adding 10% EFS, which is the same as adding the third drug in FLOT, or a little bit less than just adding the chemo backbone in the ECF versus surgery alone studies. So I think the extended benefit is similar. Now, like you, Kate, in the neoadjuvant and adjuvant studies, EFS will go, well, that's nice that you've got EFS, but show us your survival, because actually that is the gold standard in the perioperative and adjuvant setting. So I always try and ground myself in what are our standards and what are our benchmarks. And then, of course, you go back to your ESMO scores and you start saying, what is the benefit and landmark analyses into your hazard ratio and your EFS at your landmarks. And actually, that comes out pretty well. The FLOT with development comes out pretty well. I think it's a B in ESMO, which is decent in the curative setting, and it accepts that early EFS is okay in some settings. And also bearing in mind that in gastric cancer, the addition of immune therapy in adenocarcinoma isn't curative. So it's PFS enhancing and OS enhancing rather than actually salvaging and curing people. So I think getting EFS in a solid tumour like gastric is actually a meaningful intermediate endpoint. Of course, we want overall survival, but it's a pretty decent intermediate endpoint for now. I hate PCR because I think that largely is how hard do your pathologists look, how many sections do they do, how much time do they have, and how good are they? And of course, you saw in ESAPEC that PFS and PCR were not related at all, and that your PCR rates were higher in the arms that got radiation, but that didn't necessarily translate.
No, they were. Sorry. They were higher in the FLOT arm.
Sorry, I'm not. I'm going to ESAPEC confused. AEGIS, AEIGIS. Which was cross versus ECF. Of course, your PCR rate was higher with carbotaxol radiotherapy than it was with ECF chemotherapy, but that didn't translate into a survival gain. The curves were superimposed.
Yeah. Anyway, we can argue about this for ages, but I do think we're missing something. And
yes.
And I hate the fact that we are, if you think about a numbers needed to treat, we're still at 10 at $100,000 a year, and that's not good enough.
Well, so, the cost component of that's high, Kate. The numbers needed to treat for perioperatives 10 as well. 6 to 10. So it's treat for Herceptin, 20.
We are running out of time, but I'm just going to quickly mention the FDA released on the 18th of August a new guidance on endpoints in clinical trials and emphasising the need to have overall survival as a primary endpoint. Talked about the circumstances in which it could be a secondary endpoint. Talked about when we needed adequate crossover designed in studies. So this is sort of an issue that's come up multiple times on the podcast, but there we are, a new FDA guidance, and I would urge the clinical trialists listening to have a look at it, and also trainees to get some understanding about endpoints in randomized clinical trials in oncology.
We should perhaps also schedule a bit of a chat about crossover at some point, because that's a critically important issue. You sometimes have crossover which must be done, and other times where crossover must not be done. So that'll be good to dive into that. Really look forward to reading that paper on FDA guidance, and so glad the FDA is listening to the wisdom of the common sense oncology movement, which is calling for good endpoints outcomes that matter to patients.
Yeah, that's right. And that issue about when to include crossover and when not to is discussed a little bit in this guidance as well, CJ. All right. Thank you. It's been a real Cook's tour in various topics in oncology. I hope people found that at least one of those papers of interest. As always, a pleasure to discuss it all with you both, Professor Jackson and Dr. Kate Clarke. Thank you very much.
Kia ora, Craig. Hope you stay well.
I'll try to. And thank you, our producer, Rachel, who's been herding us along while we've been recording this. Thank you, Rachel.
Always a pleasure. Thank you, all of you.
Thank you. I'm off to have my cup of baked beans and my 30 mils of olive oil.
I was just wondering if you're going to say that you're going to have some baked jeans there, Kate.
That's what I did say. I think I got stuck in a thought thing. Yeah, that happens. Menopause is not fun.
All right.
See if I could work in a gooning joke in there, Craig, but I couldn't quite work out how to run that in.
No, leave that alone. Thanks. Bye.
The Christmas special.
Bye.
Thank you for tuning in to the Oncology Journal Club podcast, proudly brought to you by the Oncology Podcast, part of the Oncology Network. For healthcare professionals seeking regular news updates and insightful discussions, we invite you to join our community at oncologynetwork.com.au. Your free registration includes a complimentary subscription to our weekly publication, the Oncology Newsletter, a valuable resource to stay updated on the latest advancements in the field. We value your input and welcome your feedback and paper recommendations via our social media channels, email, and website. Your insights help shape the conversation and drive the direction of future episodes. This is Rachel Babin signing off for the Oncology Journal Club podcast.